What is rehab or rehabilitation? My name is Fred Vigueras, a board-certified sports and spine medicine physician in Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab podcast. All right, let's talk about rehabilitation. When I came up with this particular topic, I really had medical students or students in general and residents in mind because the term rehabilitation is quite vague, and I think that it is very important that we dive deeply into, what rehabilitation means, but in the context of this podcast, I'm going to talk about what rehabilitation means to me. I think it's different for everybody, but from the time that I was a medical student up until now, I think my concept of rehabilitation has certainly changed, particularly in how I talk to patients, because again, I think rehabilitation is so vague that even if the patient wanted to go online and look it up, it's still not very specific to that person. So I wanted to start off at least with the World Health Organization definition of rehabilitation, which is a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. Now, in my mind, simply put, rehabilitation is a very complicated process. There's a lot of moving parts. There's a lot of players involved, including the physician, primary care physician, physical therapist, occupational therapist, speech therapist, chiropractors, acupuncturists, massage therapists. And so rehabilitation in general can involve a lot of different people. And I personally look at patients, the condition that brings them to me. I try to identify what their overall goals and what they are receptive to in terms of tools. And I establish their rehabilitation program based off of that, because it can sometimes be very cookie cutter, particularly if you come out of residency. It's like, okay, you get the condition, you get the diagnosis, you order imaging, you send it off to PT, OT, speech, and you don't really think too much about it. So I definitely think there, at least in the outpatient private practice world, you have to be a lot more cognizant about who you're sending people to, because it's not as multidisciplinary. There's not as much. It's much harder to communicate with the different players on the team when you're outside of an academic setting. But the first thing I believe you have to do when it comes to rehabilitation is to set goals. And I'm not talking about goals that the insurance company or the hospital. I'm talking about, generally speaking, I think you need to have your own clinical goals. Short-term goals and then long-term goals. So short-term goals to me includes primarily the activities of daily living, how they get dressed, how they get in and out of bed, onto and on the toilet, personal hygiene, how well they sleep. I think you definitely have to have a strategy for that, and you will come across various factors that might limit that particular activity. A lot of times it's pain. Sometimes it is muscle or joint related. But either way, you have to, I think, focus on that particular task or goal. The long-term goals include returning people back to sport and life, and with healthy tissue, with minimal pain, and with a plan for recurrence. So that's kind of how I look at things. There's the short-term goals. Those obviously are the ones that you work on first, and then the overall long-term goals. By establishing this overall game plan, the importance of setting these goals from my standpoint is patient buy-in. If the patient does not understand the game plan, the rehabilitation course is probably doomed to be very long and potentially fail. I think if speaking as a patient, I would think, okay, I just want my pain to be gone. I want to be able to walk without any difficulty, without limping. And I want to be able to go from a broken ankle to back to the team in less than 6 weeks. So not to say that those goals aren't good for the patient, but you have to, I think, identify what their expectations are and also try and explain your expectations of how the rehabilitation plan is going to go, because it can just be a very frustrating experience, both sides. I remember distinctly, even when I was on the acute spinal cord injury unit as a resident, spinal cord injury is probably one of the most devastating injuries that any human can sustain, and the road back or the road forward is very, very uncertain. So in an inpatient unit, the main goals are to not only help minimize complications related to being immobile, but also to help the person adjust and focus on their treatment plan, because they are typically doing 3 hours a day of PT, OT, working with prosthetics and orthotics. And I remember distinctly patient family members, frantically Googling stem cell treatments and looking at prognosis, and they can be very focused on the long-term outcome, and that actually distracts the person from achieving their short-term goals, because no matter what, even if they can achieve those long-term goals, you have to go through the short-term goals. And I really lean on kind of this type of experience, because even with my shoulder pain patients, I think about that spinal cord injured patient. Sometimes people, out of frustration and fear and pain, they're sometimes focused on the wrong goal at that particular time. And until they look at that particular goal, everything is just delayed. Nothing actually starts. So outlining my expectations, understanding my patient's expectations, and seeing where they meet, is the best way to gain buy-in from their patients. In addition, it can also help both you and your patient understand their overall progress. Now, a lot of the barriers that my patients face are predominantly pain. And so it can be hard when the pain is still there. It can be difficult to know whether or not things are actually improving. And I constantly try and counsel my patients on the fact that pain shouldn't be your only measure. When it comes to your day-to-day stuff, are you able to stand longer? Are you able to walk longer? Could you tolerate the pain more today than you did prior? That to me is a sign of progress. And it's not for a lot of patients, because some people say, I'll ask them, I always ask this kind of question of like, how much better are you? And it's a very open-ended question, and I'm not talking specifically about pain and range of motion. It's just kind of like I'm measuring the patient, just trying to get a sense of where they are mentally. And people will say, like, let's as an example, I'm like 80% better. I'm like, great, that's awesome. That's what I hear, 80% better. But then when I ask them, well, how are you doing? As a follow-up question, and then they'll say, I'm no better at all. And so I kind of almost started asking the patients right back. And I reply, well, like, so you're no better at all, but in what sense are you 80% better? And, they will give me their list. I can do this, I can do that, I can do this. I've even had patients say, oh my gosh, I'm doing amazing. I'm not doing this. I'm doing this. I'm doing, I'm walking, I'm sleeping. And I'll ask them, so how are you? So what percent better are you in the big picture? And they'll say 0% better. And, as a young clinician, I was like, well, that makes no sense, but then as I got more experience, I really started to dive into how and why they're answering those questions the way that they are. And I think once you start to understand the question and the goals, you'll kind of see the patient's true answer. Physicians are great, quote unquote, great at asking, like, what percent better are you? It's a very objective way for a very vague answer to come back. And so I think I really started asking them a little bit more in order to actually measure the overall progress, because whatever is missing in that percentage is what is probably the most important to them. My role as a physician is to make sure that that percentage goes up along with their overall expectations. So it's almost like we're kind of trying to meet at the same place at some point in time. And so I tend to really try and explain the goals and give my experience to the patient of how they do overall, what things are expected at this particular point in time, even though that they have pain. I think it actually gives people a lot of, at least some reassurance that, okay, I'm still hurting, but I'm not in the same position. I'm actually moving forward. And as a young clinician, you don't have that experience yet. And that's a lot of the reason why I'm doing this podcast is I want to share the big picture. Is a young clinician, you don't have a lot to pull from just yet. You're very focused on, learning how to diagnose and not making mistakes and making sure that your procedures go as planned. But, sometimes with that learning curve, we lose focus on the bigger picture. So again, another big reason to do this podcast and emphasize the importance of goal setting. Now, I'm going to circle back to some of the short-term goals. So one of the major short-term goals is structure stabilization. So if you're talking about a tear, you're talking about a fracture, sometimes structure stabilization means surgery. And that can be with an acute injury, or if you have someone with a partial rotator cuff tear, but they're not progressing in their rehabilitation program, sometimes you do have to go back to surgery. The other thing to consider is when talking about structure stabilization is the person's regenerative abilities. And I'm talking about their innate regenerative abilities. So sometimes you just need to give the body time for it to heal and for the tissue to reorganize. Sometimes you're talking about getting them into physical therapy or working with some sort of treatment to encourage regenerative healing. Sometimes it's biologics with platelet-rich plasma, stem cell, or biologic treatments. The goal of those particular treatments is to accelerate healing, but accelerate it back to a normal versus a normal healing rate. It doesn't actually make the process. Biologics don't actually make the process happen faster. In my opinion, it's really trying to encourage tissue that's not healing well to start to heal, but it's starting to heal at the typical rate. So it's not like actually making things faster. But again, I kind of go off on a tangent. But structure stabilization can come by one of two ways: natural healing or regenerative processes. Sometimes you use augmentation with biologics or physical therapy. But the second thing is sometimes surgery. You have to stabilize the structure, reconnect the structure, and that's part of the short-term goals. Now, in this same period, you're trying to do two other things. You're trying to prevent secondary loss, which means you're trying to prevent the primary structure from losing muscle, from losing range of motion, but also slowing down abnormal movement patterns. And when you're talking about someone with a lower extremity injury, you're really not you're rehabbing kind of multiple areas. You're not rehabbing just the injured leg. You're also trying to treat and prevent complications with the supporting or the uninjured leg. That could definitely happen also with time. The third thing to mention is loading. You have to learn how to load healing tissue which is different from loading normal tissue. And I think that sometimes is a step that patients will miss, or might be a point where they don't understand, is that even if pain is not part of the issue, if you're in that healing phase, you still have to learn how to load healing tissue, which is different from normal tissue. So you're used to doing like squats in the gym and you injure your knee, you have to load that tissue slowly because it's still not completely organized and healed yet. And so some people talk about, oh, like I can squat this much. What is PT going to do? What PT is going to do, or any movement that you're going to do, you have to learn how to load the tissue slowly, or with a certain intensity or a certain amount of time. And that, I think, is actually really very hard for some people to understand. But again, it's our role as clinicians to help explain the difference between loading normal tissue and loading healing tissue. It's not necessarily, just don't do this or else you're going to tear things. Even in a reconstructed structure, like a reconstructed ACL or a rotator cuff tear, you cannot load that tissue, too quickly. You have to treat it very, very differently. And it's a slow process, and it can be a source of frustration for patients. And the patients will often kind of bring that up to us, and it is our job to help them understand what's going on. The last thing I'll mention in terms of the goal of rehabilitation is learning. And I'm talking about learning for the patient. There is a difference between habilitation and rehabilitation. Habilitation is essentially a lot of rehabilitation is about learning and unlearning, to be honest. When people have a chronic injury, they adopt, essentially some bad habits and some compensatory patterns. And once the primary issue is managed, part of the rehab process is trying to unlearn the pattern that they've had to take because of that injured structure. So that is a big part of the rehab process. Now, in terms of learning, the treatment options, from my standpoint, there's non-surgical versus surgical. And the non-surgical options, at least from my standpoint, is injections, physical therapy, bracing, behavior modification, learning how to return back to certain activities using a graded scale. And obviously there's also surgery. But, more important than that is actually learning how your body responds to treatment, whether it's surgery or non-surgical options. As a patient, I think there is a little bit of a blind spot that we think that we all respond to everything. And the truth is that, not everybody responds the same way to certain treatment options, meaning like I've definitely had people that have had very clear surgical problems, but have had multiple surgeries, and they just typically do not respond well to any surgeries they have. They're just not they have weird complications. Things tend to come back, and it's nothing. It's almost maybe just bad luck, but they just don't respond well to a surgical option. Conversely, some people will also not respond well to physical therapy or to injections or steroids or things like that. And it comes along with time and experience of you learning your patient, how they respond to certain treatment, how they accept certain treatments. Some people just are like, they just don't want to do certain things. So the learning kind of goes both ways. It's not just the patient understanding what treatment options are available, their preferences, how they respond to it. Even as a clinician, I think it is part of your responsibility to learn your other patient, how they respond to things, what they don't respond to. To me, that's the same thing as understanding a person's allergies. That's really at the heart of a good treatment and rehabilitation plan, is understanding the options available and how they're accepted or received. But I just wanted to give a general overview of how I view rehabilitation. I encourage you younger clinicians just coming out on really trying to understand what a rehabilitation program looks like to you, because we can get very stuck, especially with some of the treatment options, surgeries, injections. We just kind of assume that once that part is done, that things just kind of go back to normal. with time, quote unquote. And when you kind of branch back out, at least in my mind, structure stabilization is a short-term goal. So there's still a lot more to learn and to consider when you're trying to rehabilitate an injury and prevent recurrence from coming back. And we can be very short-sighted that way, not just as patients, but as clinicians, that I just need this body part to be normal and everything will be good. And realistically, that's not the way things play out. So anyhow, I just some food for thought about how to view the rehabilitation process. I hope you guys learned a lot. Thanks again. Thank you for listening to the Talking Rehab podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.